Hello, everyone, and I thank the organizers for inviting me and for the wonderful conference. They've organized the beautiful events, the wonderful program. Great job. Sorry, we're right into the 1 hour postprandial state, I think, so if you do fall asleep, I can understand. I will briefly talk about the ICQC, which is the International Carbohydrate Quality Consortium, and what we've done so far. I wrote a few slides, I prepared a few slides last night, and it was during a hypotension event or evening, and of 88 over 52 millimeter mercury. So I was trying to put this together. So if I'm missing something, I'll blame it on the hypotension, while my colleague was suggesting me to drink a lot of water and keep my feet up and lay down. And by doing all that and finishing the presentation was a bit tough. So is there any particular diet for hypertension and trying to gain weight? I'd like to know that later. Okay, so I will just my disclosures. I don't really have any myself. The ICQC meeting we had this Tuesday. It was supported by industry, and I am a member of the ICQC group. The supported the industry who supported us for the meeting last Tuesday, you can see here, and also the research group, the Toronto 3D, who organized this conference. So this is a nice picture, I hope you think. So a couple of years ago, a bunch of researchers around the world decided to get together in Stresa on Lake Maggiore in Italy, just below the Alps. On the other side, you can go and visit Switzerland. And this is about maybe 80 kilometers from north of Milan. But we didn't go there for a holiday. We went there to talk about carbohydrates and to talk about science, particularly around carbohydrates. So this is what we organized 2 years ago. That was June 6th and 7th, 2013. This meeting was co-organized by the Nutrition Foundation of Italy and Oldways USA. And with the intent of writing an international scientific consensus summit. Basically, we organized the summit to write the consensus. So we wanted to go through the science behind it and see what we could agree on and what we didn't agree on, where the gaps were, and discuss and try to move the science, the carbohydrate science forward, hopefully. So that's what happened in June 6th and 7th, 2013. So we had this summit on the glycemic index, glycemic load, and glycemic response in Stresa. We wrote a consensus statement because we thought that it was important for scientists also to clarify, to know what was thought by the experts in this area of glycemic index, glycemic load, and glycemic response. The ICQC is a non-profit organization, and it is international. It was created in response to scientific, governmental, public needs to have more clarity on the science around dietary carbohydrates, quality, and health. And these are the founders, or well, most of them. Maybe there were a couple missing. In fact, we are 21 members from 11 countries over 3 continents. And all the members and chairs are academic scientists or from non-profit organizations. The chairs are David Jenkins and Walter Willett. And the members are listed here in alphabetical order. The ICQC mission is to support, summarize, and disseminate the science around dietary carbohydrate quality and health. And we hope to find solutions or identify the gaps and find possible solutions, creating new collaborations, encouraging scientific dialogue, and harmonizing the carbohydrate discussion within and between academia, industry, and governmental bodies. We plan to meet at least every 2 years, and the last meeting we had was last Tuesday, June 9th. So what we did so far since June 2013, since we formed, we wrote a position letter on the GI labeling, which is published in the British Journal of Nutrition. We also responded to several calls, the Health Canada call on postprandial glycemia, the UK Scientific Advisory Committee on Nutrition, and Diabetes UK. We also wrote the consensus statement on glycemic index, glycemic load, and glycemic response, which is in press in the Nutrition, Metabolism, and Cardiovascular Disease journal. And that is it. I'm not lying. It is coming out. So that's the one. And I got permission to show this from the journal. The consensus statement that is about to be published includes 20 points, but I'm just going to summarize it briefly here. The consensus was that low GI and low GL diets were relevant to the prevention and treatment of diabetes and coronary heart disease and possibly obesity. The group affirmed also that low GI and GL diets should always be considered in the context of a healthy diet. And I think we've heard that quite a bit also during this conference, complementing other ways of characterizing carbohydrate foods, such as fiber, whole grain content, and so on and so forth. Another important point was that low glycemic index and low glycemic load diets are particularly important in individuals with insulin resistance. And given the high prevalence of diabetes and prediabetes worldwide, and the consistency of the scientific evidence that we reviewed at the time, but it seems to be still fairly consistent, the expert panel confirmed the urgent need to communicate information on the glycemic index, glycemic load to the general public and health professionals through channels such as the National Dietary Guidelines, food composition labels, and food labels. Sorry, that was food composition tables and food labels. And, this is probably the hypotension effect, sorry. So that is the meeting. That's what we had I talked about last Tuesday. So we discussed the progress on glycemic index, glycemic labeling and guidelines, the latest research and future direction on GI and GL. And also we wanted to know more about other healthy carbohydrates. There were discussions about that. There was a discussion from the industry. And also we discussed our future, the future of the ICQC. Regarding the first point, the progress on glycemic index labeling guidelines, there were methodological discussions. It was presented also this new program from Australia, the GI Lab Accreditation Program. We discussed opportunities and barriers of GI labeling from the Canadian and European perspectives. Regarding the latest research and future direction on GI and GL, we heard Frank Sachs talking about the OmniCarb study and its interpretations. We heard Jenny Bremiller talking about the previous study, and we discussed latest findings from the low GI studies in Toronto by David Jenkins, new GI measurements and in vitro pasta studies results. Another point that we discussed was the other healthy carbohydrate diets. For example, there were a lot of discussions on whole grains and lentils, fructose, and viscous fibers. The industry perspective included discussion on talks of low glycemic index snacks, snack bars, novel slowly digestible carbohydrates, starch digestibility and glycemic responses, lowering glycemia with novel carbohydrate ingredients, and supporting the GI message in general. We planned also some future activities. These are just some of them. Of course, we will continuously promote the good quality carbohydrates and research on carbohydrate and health. will promote the GI accreditation programs, which aims at standardizing the GI methodology in GI labs globally, and hence it will help to improve reliability and reproducibility of GI values, and particularly to develop country-specific GI databases. And we will also work on the ICQC reporting guidelines for glycemic index, glycemic load in dietary assessments in epidemiological studies. This is to improve the reproducibility and comparability of GI-GL studies. And I think that the GI accreditation program will help in this direction very much. Also, there is, of course, a lot of focus around carbohydrate in terms of disease risk reduction, in terms of diabetes and coronary heart disease, but I think we need to also look also into cancer, particularly secondary prevention. And we discussed funding, of course, and that is the usual issue that we all have. And hopefully, if some of you that supported us like our work and would like to continuously support us, that would be excellent. We can discuss that afterwards. And I would like to thank you all for your attention, and thank everyone that made this possible. Thank you.
Well, thank you very much. So, dietary guidelines. I start with some disclosures. These are the companies which support the dietary guidelines. So there is a number of them. We do need money from other agencies because the EASD, who is actually behind these guidelines, does not support them with any money. So we do have some unrestricted grants, and we are very glad for those. Personally, regarding grant support, this is a company which makes fibers, actually. These are state research funding organizations. Unilever and Beneo paid some honoraria. Okay, this is about the grade system, the guidelines, so there's no influence from anything else. And I don't have a dog or so, which will mitigate the risk of bias. So why do we need new guidelines? Well, the old ones are from 2004. I think they're still quite valid and excellent. But something has happened in between, so it's time to update it a little bit. And so we have started slowly to get going to accommodate novel data and, well, to answer some of the public issues which have come up about lipids. Carbohydrates are almost as bad as saturated fat these days, for some people at least, and some people promote some diets. So there are some answers to give. We have a guideline group. You see all the names listed here, and we're addressing a couple of macronutrient topics and have grouped that a little bit with the experts we have in our DNSG group about lipids, proteins, dietary patterns, carbohydrates, dietary patterns, carbohydrates, and prevention of diabetes. And many of the people who you see listed here are present today, and we will soon discuss further guidelines. So one chapter which is quite close to being finalized is a protein chapter. So what are the issues around protein? One is it's not addressed by any of the current guidelines. The Canadian guidelines say it doesn't play any role anyway. The American guidelines actually do not say much about it except for renal insufficiency. And the UK guidelines also don't mention it too much. But it does receive extensive support, and you heard Osama give his talk. So there are many people who tell you if you eat high protein diets, your diabetes will be solved and there won't be any problem. You will have great weight loss. It's strongly satiating. It reduces weight regain. This was shown, and Wim Zares reported these findings. So there's some evidence, and it's also in the longer term. Then diabetes glucose control. If you don't eat carbohydrates, you will have much less postprandial glycemia. So it should work great to reduce glucose and should reduce the requirements for insulin. Actually, the IDF also has a strong group which says so. And it increases postprandial energy expenditure and reduces sarcopenia. So there are many good things which people claim. But is that true? So the other part is, if you look at high-protein diets, they actually activate the branched-chain amino acids proliferative pathways. And there is evidence, and it's not strong evidence. It's actually from an NHANES study, and I don't think the data are very good. But what they say is that if you are young, your risk of developing cancer, your time until cancer will be much shorter. And the headline in the New York Times, and Herzl told us that this is the important thing to go for, was eating protein is as bad as smoking. So protein may have some disadvantages. If you get older, though, it seems to be much better. Then it takes much longer to get cancer. So perhaps we need age-adjusted guidelines. So there are some issues around it. So the issues are, we felt that a more balanced view of the advantages is urgently needed. So is it really the solution to everything? The risks of high-protein diet need attention, as I just mentioned, and the effect size in diabetes control needs to be communicated based on evidence base. So we sat together and defined the criteria which we wanted to see: 50% diabetes patients, 20 patients or crossover design, 8 weeks duration at minimum, documented difference in protein intake, and then looked around for meta-analyses which fulfill the criteria of the GRADE system, which is the system which we wanted to apply because we felt it's adequate. So then you have to describe the PICO criteria, population, intervention, and the comparator. So it was high versus low protein, more than 20% was high, below 20 was low, and population type 2 or type 1 diabetes. So then the outcomes. We heard that the outcomes are the really interesting thing, and the only really relevant outcome is if you live or die. I don't think that's entirely true. So for diabetic people, it's microvascular and macrovascular complications, of course. And we all know we do not have any data on these endpoints. So actually, we can stop making guidelines. I mean, we don't have real evidence, but we can perhaps say a little bit about it. So these irrelevant things like metabolic control and the somewhat relevant things like anthropometry are still points you can address. And we put that on our outcomes list. Then we used Review Manager version 5.3 and did a meta-analysis according to our criteria. There are 3 published meta-analyses which do not fulfill our criteria and which have quite severe drawbacks in our view. So if we do that, what about the weight? And I'll very briefly go into that. Well, the published studies which achieved a difference report a weight difference in all weight loss trials, by the way. There are virtually no weight constant trials with high protein. And there is a 1.1 kilogram difference. So that means the control group also lost nicely weight, something like 3 to 10 kilograms, depending on the trial. But the difference was only 1 kilogram. So it's somewhat helpful. And this agrees, I think, with other data, for instance, from the Diogenes study, where we also saw about the same number. Sorry, was this really? Yeah. Okay. We also did all this quality rating of the papers, and well, they're always non-randomized, of course, the interventions, but otherwise the trials were of good quality. So when you go on the metabolic control parameters, HbA1c, there's actually no difference if you use high or low protein diet. And this agrees with most meta-analyses which take a little bit longer-term studies, which it doesn't really say that you can't nicely lower HbA1c with high protein diet, but people are not compliant. That's one of the points. But even if you achieve a difference, it's not so great in HbA1c. Fasting blood glucose, also there's no significant difference. If you go to the lipids, there is no difference, high or low protein diet, either high or low lipoprotein and triglycerides, which I don't show here. If you go to blood pressure, there is a difference. So blood pressure is lowered, which agrees, by the way, with many of the trials in non-diabetic people, and which is a finding which is of some relevance, I think. So if you group that together and then you do this grading system, actually we only have low evidence for all of these outcomes, and we cannot make any strong recommendations according to the rules of grade. So we can say, well, what we say, I will show you in a moment, is not decided. Then an important thing, of course, is the question of diabetic nephropathy. So what happens in people with nephropathy? This is type 1 and type 2 diabetes patients. There are quite a number of trials. There are actually quite a number of meta-analyses. And there is no change here in glomerular filtration rate, which agrees with a Cochrane analysis from 2007 and 2009. There is another one by Nesu and co-workers, which actually sees an 8 milliliter difference, greater decline in high-protein diets for glomerular filtration rate, but they pretty much question their own results. And if you go for proteinuria, there's also no significant difference. So there are also trials about high protein from the 2 trials, actually, which also do not see a disadvantage of high protein diets with people with diabetic nephropathy. But nephropathy in most cases was only albuminuria. There were very few patients with really low GFR, so we don't feel we can be too safe. So what are we going to make out of that? Well, tomorrow we'll have our guideline meeting, and then I hope we make some progress and can say something about the protein part of the guidelines. We are working on the other parts, and the members, which I showed you in the beginning, will report where they are, how it's going on. These great things are a hell of a lot of work. I mean, the real professionals here from Toronto and so know that. They do that, well, a lot of the time at least. And for a guideline group, it's quite difficult to do progress here. So we're very happy that actually John and Cyril and the other people here are taking over parts of this, and you saw them on the guideline list. And we hope that the European-Canadian guidelines will then make some progress. Thanks, I'll stop here.
Jenny Brand-Miller, University of Sydney. My questions for Dr. Pfeiffer. You classed a diet with 20% of protein as energy as protein as a high protein diet. I'm wondering whether that's a little, I don't know. The reason I question that as high is because the average intake of protein amongst Australians, according to the latest, national dietary data, is above 18%, 18.5%. And so there are many people already consuming 20%. So I would have thought perhaps above 25% might be actually distinguishing something more profound about high protein diets.
Well, that's a point we discussed quite a bit. In Europe, if you look at the data which were published from EPIC, for instance, and so the protein intakes are around 17%. And actually in most trials, in these meta-analyses, they were a little bit higher, but this was only weight loss trials. So on constant protein intake, people are around 20%. But this is only if you take some under-reporting of protein intake into consideration. So the numbers are rather 18%. But I pretty much agree with you. This is what we used for the selection criteria. Actually, most of the studies targeted higher protein intakes. But for instance, if you take the Diogenes trial, we targeted 28% and we reached 23%. So even if you really provide, and this was even in the supermarket centers, if you provide protein, you don't get people above 25%. This is just some radicals, And so I don't think that is realistic. But the 20% is probably a limit. But if you look at these risk factor things, from the NHANES study, Levine and co-workers, they also used above 20 as high, and those were the guys with a higher risk in cancer.
Thank you. Yeah, last question. Please.
Very short question for Livia. Why you not met also the low glycemic index for protection? Why you met only for second prevention of cancer? If you're true, of course you can put a primary prevention.
Yeah, because
yes.
Because
there
are several studies done on primary prevention, so in epidemiological studies, but there is a need to look at also clinical trials. People with high risk of developing a cancer, people who had cancer may have recurrence of the cancer. There is a mechanism behind that could support the hypothesis, the Warburg effect, for example, but also IGFs and so on and so forth. So I think it could be looked at in secondary prevention. There is some evidence for primary prevention, and We just think that also the data is not very clean, so that's why we're also thinking to look at or create some guidelines for reporting GI and GL in dietary assessments of these epidemiological studies to try to tighten the data.
Thank you. Thanks. Thank you very much for presentations and questions. Now we close this session.